Hi, everyone. Good evening to those of you joining us from India, and a good morning to those of you from the western part of the world. We are all here for this event, which is a panel discussion organized by Indo-US Rare on the theme Financial Advocacy in Rare Diseases, the Indian Scenario. And this is part of a project that is funded by Global Genes. For those of you who are here for the first time, a brief overview about Indo-US Rare and the work that we do. Indo-US Rare stands for Indo-US Organization for Rare Diseases. We are a non-profit 501c3 public charity, and our mission is to accelerate access to affordable therapies for rare diseases, targeting communities globally with a particular emphasis on India and the Indian diaspora. And our approach towards achieving this is to improve the diversity and inclusion in clinical research and building collaborative bridges between the East and the West hemispheres. Just a snapshot to understand what is the key gap that we are trying to address. What you're seeing on the screen is a global distribution of rare disease clinical trials that have been listed on clinicaltrials.gov, which is the world's largest clinical trial registry. And as you can see in bright red are the US, and slightly behind in orange is the EU. These are the places where most clinical trials happen, and the rest of the world is far, far behind. And India has a very abysmal number of rare disease clinical trials, even though we contribute to over 25% of the world's population. What this represents is a severe lack of global diversity, equity, and access to clinical trials. And there's severe underrepresentation of the Indian diaspora in genetic databases, as well as rare disease registries that may contribute to this discrepancy that you see in the world map here. And very, very little engagement of the Indian subcontinent in research and development for rare diseases. So to address this, our mission is five-pronged. What we want to do is to be able to connect rare disease patients in India, US, and globally, build collaborations for rare disease policy and research development, and also implementation of these policies between US, India, and other countries. We aim to bring together stakeholders of rare diseases by organizing national and international conferences and events like we are at right now. We also facilitate cross-border research collaborations for a number of rare genetic disorders. And we advocate for rare disease patients on a global, national, and international forum. This is a brief overview of our key programs through which we are working towards improving diversity and inclusion of rare disease research globally. As you can see, the patient is the center of all that we do. This is the focus. And our programs include education, outreach, and awareness with partners such as Global Genes, research, which includes grant-funded research, as well as our research core, which is a network of research experts from across the world, through which we are able to help connect patients to the latest in their disease. We also have collaborators within India and elsewhere, through which we're able to do small research studies to understand, for example, the epidemiology of rare diseases within the Indian context. We have our tech-driven patient concierge, through which we are able to provide personalized individual information support to patients who reach out to us. Most of the patients who have connected with us are from the Indian subcontinent or of Indian origin globally, and we have been able to connect them to the latest in terms of treatment, second opinions for experts, and also help them access treatments that might not be available to them because of their geographical locations. We also advocate for rare diseases and cross-border collaborations in biotechnology in the US and in India in collaboration with a number of partners. We have a corporate alliance built up of companies who have an interest in the space in India. And our Patient Alliance program is a platform where we have a number of disease-specific groups come together to form a coalition to drive the cause of rare diseases and collaborations. This is a brief, a snapshot of our impact in the almost 3 years that we have been in existence. We currently have 32 Patient Alliance member foundations who collectively represent over 500 rare diseases and 20,000 patients across the world in 50 plus countries. We have over 11 global partnerships and collaborations, 5 corporate alliance members, and we have taken part in a number of global events and hosted many as well. And we have raised over 100,000 to donations and grants. We also have submitted policy inputs to the US FDA, the US Congress, as well as the Indian government, specifically focusing on improving diversity and data sharing. A shout out to all our nonprofit and industry collaborators and partners, as you can see here. These are the core of what we do. These are logos of all our Patient Alliance members, few of whom have joined us today, especially a big thanks to one of our Patient Alliance member representatives who's on the panel, and we will meet him later. And we are very fortunate to be able to work with these highly driven individuals to support the rare disease community. So how can you engage with Indo-US Rare? If you are a patient organization, apply for Patient Alliance membership and work with us towards the cause of supporting rare disease patients. Industry partners sign up for a corporate alliance. If you're a researcher or a clinician, join our research core. You can, of course, always subscribe to our newsletter to stay informed about the work that we do. Reach out to us to discuss possible collaborations, partnering, or sponsorship, and also refer others who might need our help. You can volunteer your time, and there's a form that you can fill out on our website, and always connect with us on social media and other channels, or simply write to us at admin@indousrare.org. Now, moving on to the reason we are all gathered here today. This is today's event, the discussion on financial advocacy in rare diseases, the Indian scenario. Just a brief overview. This project was funded by Global Genes through a grant that we received called the Financial Advocacy in Rare. And this project was led by Ms. Ramya Karur, and a special thanks to our volunteer and intern, Ms. Preeti, who has handled a large amount of the data analysis and writing. To provide a brief overview, the project involved understanding the scenario in India based on literature analysis and surveys and interviews with over 40 stakeholders, which included patients, patient advocates or caregivers, as well as payers, grantors, or health professionals. And a few things that we learned after speaking and listening and understanding the viewpoints of many of these individuals is that the patient advocacy organizations are understood and recognized as important sources of disease-specific information, hence highlighting their important role in the rare disease community. And the highest representation of the patients and the stakeholders we spoke to was those representing pediatric onset rare diseases. Most of them were diagnosed before 10 years of age, and very few also spoke about their experiences with adult onset rare diseases. A few key findings from our work in this project were along the 3 themes of financial awareness, financial well-being, and access to insurance. In terms of financial well-being, over 50% of people that we spoke to and surveyed said there was no approved treatment for their rare disease. And most of these involved high cost, long-term treatment, if at all they did have some sort of treatment available. None of the persons surveyed had received any sort of financial support for diagnosis or for treatment. And the general opinion was that the financial hardship that they had to face was mainly due to their diagnostic odyssey and expenditure due to the high costs of treatment. In terms of awareness of what exists out there for financial support, most were unaware of any government schemes for financial assistance for their rare disease. This could come from a number of reasons. They were unaware if their disease was included in the recognized list, or they were not sure if they were eligible because of their socioeconomic status. They said there were no private funding support for their specific rare disease. They were not aware of humanitarian access programs for their disease. And health professionals we interacted with identified the main gap in financial awareness as the ability to manage healthcare expenses and make sound healthcare decisions due to this. In terms of access to insurance, over 95% said that they were unable or denied health insurance because of their diagnosis of rare diseases. And those who did have some sort of insurance had gotten it prior to their diagnosis and were still dependent on those schemes. And what claims that they did use were mostly for hospitalization and surgeries, followed by expenses for medications. All non-medical claims were attributed to assistive devices that might help support their lifestyle. This is just a snippet of the findings. The report will be released soon, and we hope you all will be able to go through and find it useful as a resource. Moving on to the main session today is a panel discussion on the topic of financial advocacy in rare diseases, which will be moderated by Dr. Bhaskar Sonowal, who is an advisory board member at Indo-US Rare. I will hand over the stage to Dr. Sonowal, but before that, I have a few housekeeping points that I'd like to raise, after which Dr. Sonowal can take over. If you have any questions at all for the panelists or for the host, please type them in the Q&A box and we will read them out to the panelists. And this event is being recorded and live streamed on YouTube. And if you have to drop off for any reason or somebody was unable to attend, the recording will be remaining on YouTube for further viewing on demand. If you have any questions further to this, please reach out to us at admin@indousrare.org. Thank you. Dr. Bhaskar, over to you.
Thank you. Thank you, Disha, and good evening for two people in India and good morning to the people in the Western world. I'm delighted to actually be amongst some eminent people and personalities that will be a part of this board. As you get to hear the names, you'll realize that these are the people that have made a lot of difference to Indian healthcare. But before that, I just wanted to put forward the fact that how did it all start? There was a lot of understanding amongst our healthcare professionals, amongst the people who actually have been close to the rare disease community, and they have understood, and we understood here in India, that about 72% of the rare diseases are genetic to start off with, and 70% of these genetic diseases start in childhood. So we have a lot of information regarding that in India. And we also understood about 95% of the rare diseases have no approved treatment, even when a correct diagnosis is made. So that is another pain point that was facing the Indian, so-called healthcare community. And where the drugs were available, they were very expensive, and very few pharmaceutical companies actually manufactured them. For this reason, rare diseases are also called orphan diseases, for that matter, because we really don't have the drugs available. And the most important part is the delay in recognition and diagnosis. Now, with all these in mind, there are few people in the country. All of them actually got together and thought of a novel way of actually enabling people of India to start getting treatment for rare diseases. And that is when the national policy was constituted. And I'm delighted here because a few of the eminent panelists have actually been a part of it, and they have crafted whatever has happened in India as of today. So I'm delighted to be here and to introduce the first panelist, Dr. Madilika Kabra, a person that I truly respect and someone who has done wonderfully well in a lot of ways for the Indian rare disease community. She's, everyone knows her. So she is a professor at AIIMS, Delhi, and at the forefront of the rare disease treatment in India. She was one of the people who actually designed the entire, so-called rare disease policy. She has many accolades to her name. She's a member of the ICMR task force for human genetics, inborn metabolic disorders, and LSDs. She has many other accolades of being the recipient of the IC Verma Lifetime Achievement Award. And also, she's an outstanding scientist. She has received an award for that. And to her credit, more than 250 publications across the different journals. So it's my pleasure to welcome Dr. Kabra into the panel.
Thank you very much.
Thank you. The next panelist that we have is Dr. Shifali Gulati, another eminent personality, very well known across the world She's a professor and a program director for the Center of Excellence in Advanced Research of Childhood Neurosciences, Neurodevelopment Disorders. She is a global senior leader for the Association of Child Neurology, and has been the past chairperson for the National Guidelines Coordinator, Academy of Pediatric Neurology, IIP Executive Board member, and many more. So it's my honor again to welcome Dr. Gulati onto the board.
Thank you so much. Thanks for the opportunity.
Thank you. We have Mr. Sandeep Tripathi, who is the leading healthcare financing platform. He's got a great so-called sort of pedigree behind him, coming from IIT Bombay, and he has many so-called roles that he has undertaken before in terms of business development and raising funds, etc. He has previously worked with Cognizant and Take Care Technologies before joining Impact Guru. So he's a senior vice president here, and I'm delighted to welcome Mr. Sandeep Tripathi as well.
Thank you, Dr. Bhaskar. Really honored to be part of this discussion.
Thank you. Going forward, Mr. Samir Sethi, who is a father of a child diagnosed with Rett syndrome. He's a president of the IRSF and has conducted aggressive awareness campaigns to increase the membership across India and Nepal. He has been creating a lot of awareness across the country besides the webinars that he posts. And he has also been helpful to many parents and CROs for the clinical trials. He's implemented Samarth program for distributing free medicines to silent angels, assisted for disability certificates and health insurance for silent angels. Truly noble soul, and we are very happy to have him on board as well. Welcome, Mr. Sethi.
Thank you, Dr. Bhaskar.
Welcome. The next slide, please.
Sir, we can move on to the panel discussion as such. Yeah.
Okay, perfect. All right. So the crafting of the national policy actually brought forward a new ray of hope to many Indian patients, and it has been truly commendable on the type of work that has happened. People who have been engaged with people who are creating the policy will understand that they spend numerous days, nights, sleepless nights rather, to ensure that this policy comes into being. There are a few others who have actually been a pioneer in this advent. However, we find 9 basic elements that we've tried to identify, which needs to be addressed at some point somehow, so that we can actually create a large difference for our patients. One of them is the delay in recognition and diagnosis. The second would be the delay in seeking medical help, because there are a lot of people who actually move around and without understanding where to go. Sometimes they do face social discrimination. There's also an economic crisis to the family. Whenever someone has a rare disease, there's a huge burden on the family. That's another area that needs to be thought through. There is the whole part of expensive and mostly unavailable therapies. So in India, we find a lot of therapies that are really not there, despite being there globally. There's a lack of freely available rehabilitation, exercise, and physiotherapy facilities in the country. There is also the patient support groups who needs to be strengthened more than what they are today. And of course, the long-term funding for therapy is something that needs to be there, as well as the quality of life for these patients needs to improve. Now, these are some of the 9 areas that we've seen. And today, during the panel discussion, we'll probably try to understand as to what next for the Indian rare disease policy, what next for the patients of India. In the meantime, I can see Dr. Venkat Raman joining in. So can you put up the slide, Nisha?
Are you able to see my screen?
No, your screen is not visible as of now.
Just give me 1 second, sorry. Apologies, there is an issue with Zoom today.
No problem. So what I'll do is welcome Dr. Venkatraman. He's the founder, chairman, and director of the Neurosciences Brains Super Specialty Hospital in Bangalore. He's also the treasurer of the Asian Australasian Society of Pediatric Neurosurgery and EC member of the International Federation of Neuroendoscopy and chairman and managing director of ONNSA Research Innovation Private Limited. He's an eminent person in terms of neurosurgery, and we are delighted again to have him on board. Welcome, Dr. Venkatraman. So,
thank you very much.
Sure, thank you. So going forward, we have the eminent panelists, and we'd like to start off with some basic questions. And I'd like to start off with a person who has been a part of the Indian rare disease policy. Can you have the first question on the slide, please? So the question is, how, after having created this rare disease policy, how would you evaluate the current rare disease policy of India? Dr. Kabra and Dr. Gulati, I'd like to take your views in this regard. What do you think is the right thing for us in India, and what else should be there going forward?
Okay. Shall I answer first,
Yes,
Dr. Bhaskar?
Yes, ma'am.
So thank you very much. So I think in the beginning itself, I must clarify that for my contribution to the rare disease policy is primarily as a technical expert, you can say it that way. So the other aspects, the administrative aspects and the financial aspects were sort of beyond my purview. So me and many others who were involved in this, our inputs were for the technical aspects and the kind of diseases, the treatment, the costs, the outcomes, and so on, right? So that's a correction which I wanted to make, right? So I am not the one who actually drafted the policy. I just wanted to clear that. Okay. So as you are aware that the first policy which was declared, that was in May 17, and it was titled Rare Disease Policy for Treatment of Rare Diseases, if you remember correctly. And then that was retracted for some logistic reasons. And then later on, this new policy came in. So in my mind, the new policy is more holistic because it just says it is rare disease policy. This is national rare disease policy, a national policy for rare diseases, which is a comprehensive policy, and it touches upon all important aspects related to rare diseases. So it is not only treatment. It also includes very, very importantly, other aspects like awareness, like prevention, availability of diagnostics, early diagnosis, education of the health professionals and the parents. And obviously, a very, very important component is the treatment aspect, right? So for most of us, including the clinicians and more importantly, the patients, I understand that they have problems in getting the diagnosis, maybe because the disease is not identified early or non-availability of diagnostics in their area, and they must have visited many doctors before they got a diagnosis. But believe me that this happens in the developed world also. If you see the information, a rare disease diagnosis is not straightforward there as well. So many times the families have to visit many places before they get a diagnosis. This doesn't mean that I am saying that this is correct, but what I'm saying is that the awareness takes time, and rare diseases are the ones which are not seen by all the clinicians, so it may take time. So as far as the current rare disease policy is concerned, I think it is very holistically covered all the aspects which I have told you, and I'll focus on treatment. But before going into that, I will also add, as in Nisha's presentation, it was said that the research is not a focus, particularly the clinical trials is not a focus for rare diseases in India. And this particular policy also deals with the research aspects and has encouraged all the funding agencies to fund for rare diseases. And you must be aware that there are multiple task forces in different funding agencies targetedly looking at rare diseases, not only for diagnostics, but for therapeutic research. So that's happening across, right? Now, I think because the focus is primarily for accessibility and availability of treatment, what I would say is that in the previous policy, in this policy, it was not very clear about the finances in the first policy, though the target was treatment. So this time, initially when the policy was declared, there were three groups, as you all know, group 1, group 2, and group 3. And group 1 was one-time funding, which is under RAN, and that funding was limited to up to 20 lakhs. Second was disorders which were not very expensive to treat, like small molecule diseases and so on, and that was left to the state to treat, keeping in mind that health is a state subject. And the third group, which is the most challenging group, was for long-term treatment, enzyme replacement therapy, very expensive therapy. It was left for crowdfunding. So this was what is happening, and what has been found over this time, though we are not very old, it is like about 1.5 years, it was realized that crowdfunding or funding through CSR for group 3 diseases is not going forward, right? So this another thing which I'm not sure how many of you are aware is that now Government of India has come up with a proposal, and that is actually being implemented, that the cutoff of one-time treatment funding is 50 lakhs. It can be one time or it can be spread over time, but the limit is 50 lakhs, irrespective of the group of disorder, irrespective of the socioeconomic status of the individual, and irrespective of any state. Okay, so that's what is available as of now. But the issue remains, and that's my major concern, and I think everybody's concern is that how do you treat patients who require lifelong, long-term, very expensive therapies, and even if something comes through CSR, how to sustain. So I think the major issue here, apart from other things which are being dealt with, I think the major issue is sustainability of long-term, very expensive therapy. So I think I'll stop here and we can take it further. Thank you.
Sure, thank you, ma'am. I think your insights are always very, very encouraging. Now, you touch upon the whole part of, what it was initially treatment towards a more holistic care. And you also touched upon parts of crowdfunding, of other ancillary ways of actually funding the entire part, and how to make it more sustainable. So, those are important points to consider. But Dr. Gulati, I'd just like to ask you, because you have been at the forefront of many research areas in this country. Do you think that R&D is actually getting enough, so-called impetus, focus, at least as far as R&D in rare diseases? Is that happening for India, as far as this policy is concerned?
See, research is going on. There is lot of research grants which are going on from the DHR, from the DST, DBT, and all. But the point is, all these new molecules and the new medications, which have come up, are so expensive that in case which they require too much funding. For example, there is one proposal from DART, which was approved by the DCGI for antisense oligonucleotides for exon skipping for 51, 45, and 53. But, that has been approved for more than 2.5 years. We have taken all, myself and Dr. Madilika, we have taken all clearances from AIIMS. Everything is ready. We're just waiting for the medication, and they are waiting for the money to make the medication. So, because the fund is the amount what they need, even the research, although from financial aspect, what is getting commercially, it's going to be much cheaper, but then also it's too much. So that is why there's a problem in funding. because the cost involved here is a lot.
So we understand that there would be limitations in a country like India because we always have resource constraints. Any country would have it. But however, Mr. Sethi, do you think that there is enough so-called support that patient groups or patients are actually getting as a part of this entire policy? We understand that there would be constraints. I mean, there is no denying that fact. But is there some focus, some support on that front?
I think what Dr. Madilika just said, I would just like to add to that. Yes, it's a very welcome amount that has been enhanced from 20 lakhs to 50 lakhs right now for any kind of rare disease patient all across the country. I think the other addition which has also happened is we started out with 8 Center of Excellence as was envisaged with the policy initially when it was rolled out. But now we've got 10 centers. So, I mean, it's a good move as far as the government is concerned in terms of spreading and slowly increasing the reach to the patients, not only in terms of finances, but also in terms of physically making the centers available for the patients to be able to access the kind of treatment or the care or management which they require. Having said that, I think we also are missing out on one very, very major point, and I think which is also been highlighted, touched on by you, to say that we are talking about only 5% of the rare diseases having a definitive medical treatment available all across the country or all across the globe for the time being. The policy is not covering the rest of the 95%. I mean, we need to do something about them as well. Maybe in terms, we are talking about treatment because the policy says that the 50 lakhs is available for treatment of patients who have a definite treatment available. But what about those who don't have a treatment available? Are they going to be covered? Are they going to get the benefits of the 50 lakhs which has been envisaged as a part of the policy? That's still not very clear. At least to me, it's not clear. The second aspect is Dr. Madilika mentioned about the diagnosis. That yes, it's an odyssey which probably all over the world, the patients with rare diseases have to face a long, course before they actually are able to find a particular diagnosis for the disease that they are suffering from. But their insurance covers them for those initial diagnoses, which is absent here in India. Patients are not having access to the insurance which is available, in comparison to what we have in other parts of the world. So I think, a very important aspect which we need to look at, and I'm not saying it's solely the government's job. I think it has to be to be taken up otherwise as well, where the parent support groups or the advocacy groups, the corporates, the pharma companies have all to join hands and to bring about that change which is required so that the patients at the end of the day don't suffer. We don't have more patients' death happening because of the rare diseases that they are suffering. It could be in terms of their care management or also could be in terms of the treatment which is to be given to them. There should be if there is a definite treatment available, they should get that. And how it is to be done, I think that's what we need to be deliberating and finding out ways that the financial constraints don't actually hamper the kind of treatments which are available to them.
Thank you, Mr. Sethi. You touched upon an important point. I think, what about the rest of the 95%, right? You also talked of insurance that needs to be there. But, you must have actually researched and seen a lot of the other countries globally. So is there any country or is there any policy that actually helps in helping out the rest of the 95% with the type of holistic care that Dr. Kabra was talking about? Dr. Venkatraman, I'd like to hear your views on this. Is there something that is there globally that actually helps all patients?
Yeah, I think when it comes to the question of rare conditions, I think we should not discriminate the people. Whatever is the rare condition, I mean, all of them needs equal kind of a care. How do we provide this is a challenge now, because as you rightly said, 95% of them do not get, there is no treatment. But nevertheless, that doesn't mean that we tell them that nothing is possible. So now when we say this, that we don't have treatment, the news spreads across and they'll be running from pillar to post looking at the alternative choices. Now, one of the biggest thing that happens is all of them will be lost for follow-up. For this, as a clinician, is my experience, because the word spreads that it is not possible to treat them. Now, among the medical professionals also, at the entry point, for example, rural areas, they go to the local physician. Local physician himself will say that there is no treatment, don't need to go anywhere. So as a result, what is happening is they are getting lost in number one. Number two, they are going to alternative therapies where they be running around from pillar to post. So what I suggest is that we must have a definition, what exactly we consider under the umbrella of rare conditions. Those ones diagnosed, undiagnosed, the ones which have a treatment, those which do not have treatment. So that what happens, we need to be able to channelize all our resources, funds, actions, time to various categories of these rare diseases. Those ones who have got already treatment, I think as the fund has to be optimally utilized, the clinicians should obtain the resources to treat them at every possible center where we identify, accredit them as the centers for the rare conditions. The second thing is that once which is not there, I think certain amount of funds should be allocated for that. How do we arrive at the diagnosis? So it could be, optimization of the investigations. If you do that, blanket investigations for everything, no money is sufficient. So there has to be a panel of experts across who will give an opinion for all these. What is the ideal currently available investigations step by step, so that we are conservative at the same time changing the diagnosis. Once we have it's a structured part of investigation, the money should be spent. And lateral, simultaneously, we should also have to look at the research point of view. And these people, otherwise they remain not only rare and remain unknown as well. So we need to identify exactly what the condition is that. For that, I think we need to have a research, and then we need to have the ability to preserve their biological samples, so that if not at that point of time in future, it will be of useful to get that. It could be a biomarker, or it could be a treatment option, or a support option. And then the people who do not have the medical treatment as such, I think we need to have what is the support treatment, rather than leaving them blindly. You do what you like and go wherever you want. I think that's what is happening. And then to create the awareness, it has to be to the public, to the medical personnel, research organizations, and the government. All of them have to be participated. Now, there is a kind of an indirect funding I would like to talk about. We were all talking all about direct funding, money coming various resources. Of course, we need to continue. Not only the insurance, it should be CSR, it should be grants, the crowdfunding, high net worth individuals who have a lot of money, they should be able to give that. And Western countries, what I realize, a lot of foundations, like you have Parkinson's Foundation, Michael Foundation, so many other foundations, which support each one of these medical conditions. We do have very huge number of high net worth individuals. India also has a lot of rich people. I think they need to pitch into the medical field. Somehow they never looked at medical field so far. I haven't seen one individual coming forward and saying that this, very few and a very limited resource. I think this is something which we need to look at. We work for our own people, so that they need to come and participate and give us both to the research as well as to the treatment. Now, what I'm talking about indirect facilitation is also kind of for example, we cut short the method and the expenses, either by the structural, the requirements, statutory requirements, the DCGI requirements, importing requirements, importing tax. If the government or any other agency can help us, if there is something which is an approved drug, we don't need to go through again, all over again to do some research in India. such facilitation happens, it also saves a lot of funding. Then I think pharma industry will come forward, because pharma industry has a lot of hesitation today, because they need to fulfill a lot of regulatory requirements before they get the drug into the market. So this is one of the biggest challenges. So this, I call it as an indirect funding. If the government or whatever agency can help us to reduce this formality, one, it will cut short the time, it will cut short the expenses, and then it can be a facilitator to that. That's what I feel.
Yeah, absolutely. I think you've touched upon many important points, Dr. Venkatraman. I think that's really good. But what's even more heartening during this discussion is that we have questions from the Rare Disease International as well. And the question that they've put forward is, and this is something that maybe we'd like to ask Dr. Gulati and Dr. Kabra. There is something which is a UN resolution on addressing the people living with rare diseases and their families. So while considering the national policy, has that been taken into consideration? Because that is something that the global community really is looking at. Is there something that people are really looking at? And Mr. Tripathi, you can also bring in your views on this particular area. I'd like to ask Dr. Gulati and Dr. Kabra first.
Would you like to respond?
You can start.
Okay, so if I understand correctly, Dr. Bhaskar, what the question is needs for all the patients with rare diseases has to be covered, right? So if you go through the rare disease policy, there is clear mention about the rehabilitative facilities and about, the tertiary level prevention, that's what we call, right? And it is again presumed, and that may not be correct, that these facilities are already available in various states, which may not be uniformly available everywhere, but that has been emphasized that this the rehabilitative services, the supportive services, and I really agree with Dr. Venkatraman when he says that once the patient comes to know that there is no specific treatment available, they would leave everything. They would leave physiotherapy, they would leave out on stimulation, they would leave out everything. Just thinking, even if the patients are getting enzyme replacement therapy, we know that they need to have supportive care, and the patients do not understand that. So that's, I think, a very, very important point he made out. So that has been put in the policy. What is not clear, and in fact, as clinicians, we have been asking in various meetings, that this 50 lakhs, can this be used for things like assistive devices, some specific things which are required for a specific group of patients? So that doesn't have clarity as of now. But having said that, there are other schemes. Suppose some patient with rare disease requires a surgery. There are many schemes like Ayushman Bharat where you need to get admitted for a particular procedure. And it is not that the rare disease individuals are not entitled for that. So that exists, right? So what is probably being asked is that, does the rare disease policy address the issue for financial support, for supportive care and rehabilitative care for patients with all rare diseases, irrespective of a specific treatment availability or no? It addresses, but I agree that it probably needs more clarity, and we as clinicians and parents also need more clarity that how this amount of 50 lakhs, which is now available, can this also be utilized? And we have put up this question already in the Central Technical Committee, and they were also not very clear about it. So I think this clarification would happen soon. So I think that answers the question. Shifali, would you like to add anything? Shifali?
Ma'am, I'm introducing my other webinar. I will
okay,
join.
right. So sure, no problem. Right.
Sure. Mr. Tripathi, what is your view on this particular part? So is there, do you see the holistic approach being undertaken, people actually getting it in terms of rehabilitation? We see a lot of rehabilitation in terms of some diseases, especially related to blood disorders. But, is there something that you see on other areas? And they also talked about drugs not being available in India. So what is your concern about that? How do you actually ensure that drugs that are not there actually come into the country?
So if I talk of the Indian scenario, a lot of the healthcare insurance penetration in India, over 500 million of the middle class population have zero health insurance. So Dr. Venkatramana also mentioned that insurance covers a lot of things in the Western countries. However, these are not covered in India. So even the healthcare insurance, even if it covers a lot of other support treatments or ancillary treatments apart from the drug or the surgery, a lot of them do not have a health insurance in the first place. That is also a huge challenge which we are facing as a country. And according to the WHO, the out-of-pocket expenses on health services, especially medicines, continue to push over 55 million people in India into poverty. So a large deterrent in continuing treatments or even starting treatments in a lot of cases is the financial implication that we have to take care of these expenses on our own, or have to wait till we get certain amount of funding approved from the government or from any other body. Dr. Venkatramana also mentioned the non-financial healthcare support which pharma companies can give as one of the approaches which a lot of pharma companies have been doing is via their market access programs, their patient access programs, wherein they give a certain therapy, part of the therapy free of cost to patients who are unable to afford. Maybe the altruistic solution is not via one person. It may not be able to, one person or one organization might not be able to solve it. It is a collective, it needs a collective solution with some part being taken care by the government, some part via crowdfunding organizations like Impact Guru, a part of that via the market access programs or patient access programs via pharma companies. And of course, a lot of energy also needs to be spent towards diagnosis, early diagnosis, and the right kind of awareness which can be created both by the healthcare fraternity as well as pharma companies. I think there is no single organization which can solve the problem which we are facing or a lot of patients are facing, because with a country like ours, which has a population of 1.3 billion, the definition of rare diseases, which is less than, say, 1%, even the 1%, the numbers kind of magnify significantly.
Okay, so Mr. Tripathi, we understand that area is this. It's important to address, right? And everyone has been talking about crowdfunding and other ancillary ways of funding, right? But there is as Dr. Kabra mentioned, a lot of so-called doctors actually go through this entire part before a patient actually comes to deliver. She mentioned about the developed countries, maybe about 7 so-called consultations happen even in the UK. So in India, it could be in multiples of that. So we don't really have an answer for that. But the part is the entire part of so-called physiotherapy, rehabilitation, etc., happens once the diagnosis is made, right? So and all that happens in the tertiary so-called centers. It's really not happening. Possibly it's not happening in the lower centers. So is there a way that the diagnosis, as you mentioned, can be actually done earlier? Because we are looking at rare disease diagnosis as something which is that a person has already been diagnosed, and we can therefore get the diagnosis done at the tertiary center. But most of the people get to the tertiary center after a long wait, and maybe a lot of movement around the country. So is that being addressed, or is there a need for that to be addressed at the primary level? Is something that we'd like to understand. I mean, does the policy really have that? Mr. Sethi, what do you think? As a patient, do you actually, as a parent of a patient, do you have such facilities available in the lower areas, or do you see people that actually face problems, and what can be done about it?
The biggest challenge that the rare disease patients face is about awareness. It's a yes, the odyssey continues in terms of going from one doctor or a clinician to another before they actually are able to get a diagnosis. The challenge still remains because, you know, the early diagnosis is the key for any rare disease care, treatment, or management, as the case may be. And that's what is lacking even with the clinicians at the grassroots levels. So it's very important and imperative for for example, the Anganwadi workers, the ASHA workers, the people who are at the district levels, people, the pediatricians, the obstetricians who are involved in the childbirth, they need to be educated so that they can at least start creating that awareness, which is what is not happening. That's a personal view that we need to do that even more emphatically, because I was also involved to get a little bit of information about the RBSK program. Now there again, the reach has to go to the grassroots levels for the villages. That's where the 70% of the Indian population is. So how do they get to know whether the child who is having some kind of a ailment is actually suffering from a rare disease? And unless and until the doctors or the facilities which are available at that level, at that basic level, are aware themselves to be able to refer the child to a center where they can further diagnose or do some kind of treatment or a diagnosis for that child, is going to be a challenge, continue to be a challenge unless and until the awareness is there at that level. So it's lacking. According to me, it's not there.
Correct. I mean, that's one view that we hear across from many experts. But there are a lot of things that we can do and a lot of things that we cannot. But within the constraints of what we can do, Dr. Kabra, is there something that can be done on the awareness front? Because you are sitting at a tertiary center, you're sitting at the center of excellence. What about the others that are not actually there? How do we enable patients to actually understand the entire part of rare diseases or whatever diseases that they have, it can be treated? There is a way that it can be treated. There are ways that you can actually get to certain doctors for the right diagnosis and the treatment. So is this something that can be done, which is in our hands?
Right. So I agree to some extent with Mr. Sethi, but I think you would all agree that this awareness has really increased over the last many years. Like over the last, even I'm in this field for almost 25 years, and in the last 5 years and maybe a little more, I have seen that the referrals from the remotest places are coming to centers where the tertiary care centers. But having said that, we really need to increase the awareness. I totally agree with Mr. Sethi, because if we do not diagnose in time, even the treatable ones would not come into the cognition, and then if at all treatment is possible, it will be delayed. And to my mind, early diagnosis is not only important for doing a specific treatment, because that may not be available for a lot of them, but then to explain the parents about the need for supportive care and what can be done for the child. And believe me, a lot of things can be done for the child apart from a specific therapy. The other important reason for early diagnosis and increasing awareness is that once they have one affected child in the family, depending on the inheritance, the risk of recurrence increases. And many times we have 2, 3, 4 affected children in the family, and then they come to us, and we really feel bad that the diagnosis was not made early. So efforts are on. But I totally agree with Mr. Sethi that because India being a huge country, we really need to work more on this. And just to give you a few examples, there are projects funded by DBT where there is aspirational district program as a part of it's called a Ummeed program that includes training at the tertiary care centers and adoption of the aspirational districts by various institutions. And there at the periphery, at the district level, this is being tried to train the medical and paramedical staff to pick up high-risk families. And this is being done through the antenatal, interviewing the antenatal mothers, trying to identify is anybody having this particular symptom, and there's a checklist to see that is there anybody who has developmental delay or repeated requirement of blood or has muscle weakness. So there's a checklist, and based on that, the centers which are involved in this, they take care. The other thing which was being said, that what can be done, awareness is one. So this has to be done at all levels. And I think it would be important that at the medical college level, because you were saying that the awareness is less, and why, what is the reason for this? The component of genetics teaching, and you know that 80% of rare disorders are genetics. The component of teaching for clinical genetics in undergraduate, postgraduate curriculum is not proportionately as high as the other components, and it is increasing now, but there's time now that doctors learn about at least some of the commoner rare diseases, and also know that which are likely to be these kinds of disorders, so that can be referred on time. The other way of early diagnosis is doing newborn screening, where we are as of now quite far behind, because for routine disorders like hypothyroidism, etc., there is no national program. So in the Western world, they detect it early because they do newborn screening, and they know that the baby is going to be affected, and treatment and management starts. So I agree that, and I think we all have to work in this direction. And believe me, there's a significant improvement over the years regarding awareness. Thank you.
Thank you so much. And we are actually within that half an hour, but I think a lot of questions are coming in. But
Okay,
a couple of questions are around crowdfunding. So we talked of crowdfunding. We talked of alternate ways of actually getting funds. The government has been very, very kind enough to actually get that entire funding off the ground. But we have corporates that have 2% of the entire profits above 500 CR to be provided into the CSR funds. There is also the crowdfunding that we've seen of a girl in Kerala who's raised millions of so-called rupees for the treatment of her brother. So things do work, it seems. So, but is it something? Does there need to be something which is more channelized in order to get to this crowdfunding? Because it's a very nice word to hear, but does it really work? I mean, how does it happen? Even CSR is a very nice word because a lot of companies do that. But how do we channelize that into the rare disease areas? Because otherwise, it goes into many areas which are actually important, but can we get that CSR fund into the Indian diaspora? I'd like to ask, Mr. Tripathi and Dr. Venkatraman, if there's anything that can be done around this.
Yeah, crowdfunding is possible. We do that occasionally, but is on individual patients. So there is nothing like a specific channel. Say suppose one particular patient is there, we advertise that on the net, and we advertise on newspapers. We create a specific bank account for that individual, and then we approach all the social organizations, corporates, to donate fund. So it's a one-time event that will come certain amount of fund. Part of it will be utilized for the treatment, and remaining will be handed over to the patient as well, so that for the continuation of the long-term treatment. But there is no a generalized system where it needs a lot of effort, that we need to give a lot of data to the people, to the donors, saying that to convince them. Some of the times it is purely on the availability of the fund. Second thing, how well they get convinced that this patient will get treatment. Now again, there is a myth. If the donor convinces that there is no specific treatment for this individual, and he feels that donating any money to that particular person is a waste. So he says, if there is no treatment, why do you want this? Now the point is that nobody, including the insurance, offers money for the diagnosis. This is an unfortunate problem. Now, there is a big myth in the insurance saying that if anything that exists right from the birth, they think it is congenital. I don't know where from the concept came. No parent will know that ever this child will be born with a disease. How will ever they be punished like this? So once insurance, you write that right from the birth, the child has this problem, the insurance will be immediately denied. It's not their parents' problem. It is the problem of some of the genetics which nobody can identify today. Nobody looks at the genes and gets married. There are other factors which helps them to choose the partner. So this is the first thing I think we need to correct. Regardless of all, these people have to be supported by the insurance. Parents are prepared to take the policy. but it cannot be denied. It's not the child's, anybody's problem. So it's a God's mistake, if you ask me. And we are trying to find the solution and try to correct that. So insurance should support that. Similarly, crowdfunding has a lot of challenges as of today. As I said, there is no standardization, there is no method. Third thing, though there is an option today, very few technocrats who knows this option will be able to do that. Now, any crowdfunding requires a bank account, an affiliation of the bank account to that particular thing to make it authentic. I agree. All these processes are required for the security purposes as far as the finance requirements and the law is concerned. But it should be so simplified that everybody should be able to access. Because of that, there are a few agencies which have come up, which again requires a lot of process. We need to go through these crowdfunding agencies and they need to do that. So this process, if it can be simplified, I think that is the one thing which we can do that. Now, the second thing we're talking to Dr. Madilika's comment on awareness is very, very important. Awareness, this is exactly the reason why we need to create awareness. When I talk about awareness, it's not only just to the patients. We need to talk about a multi-pronged approach. First, every public should know that medical fraternity and research organizations is putting every effort to try and solve these medical problems. So they need to pitch in the support and try to help whoever can help in whichever way, whichever capacity they can. I think number one. The public education at large is very important, not only the patient education. Patient anyway will seek the medical help. They will be running around. But the peripheral medical professionals, starting from the top, the center of excellence, all the way down to the social workers, they need to know that they give the right kind of communication and hope and facilitate them to reach the right place at the right time so that early diagnosis can help. In addition, all the pharma industry, all the research organizations, all the industry in general, corporate, medical and non-medical industries should be aware of. That's the way of education we need to create. And last but not the least, the government should facilitate this kind of education to various channels for rare diseases so that large people can be communicated. Here, we are talking about magnitude of the problem in a 2.3 billion country, but at the same time, if 2.3 billion people are aware of that, if 10% of them or even 1% of them contribute to this cause, I think this becomes a big magnitude again. And that is the way we need to look at. Now, the two important things here, we need to group them into different ways. Everything cannot be grouped under one channel. People can be treated, should be channelized. Already established treatment is there. We should put every effort and all the resources should go there. No amount should be of energy or time or money should be wasted. The people with no diagnosis, every effort should be made on the diagnosis. This is another challenge because the new things have come in now, the genetic anti-inflammatory.
I think the internet of Dr. Venkatraman is actually a little bit on the weaker side here. So we'll get back to him as we get back. So we are running again short of time, but we just like to have two questions here. One is, again, Dr. Kabra, you're sitting at a COE. There are many state governments that actually, also probably need to fund for the rare diseases, right? So how would they even think of creating their own funds if they do not have awareness in terms of what can be funded, what cannot be funded? What is
started for all the people who do not have an established treatment, for the reason, if any treatment comes in the next 6 months or 1 year, 2 years, they should be eligible enough to get the treatment. Otherwise, they'll all come in such bad shape with such severe disability. Even the treatment gets comes after a while, diagnosis, we will not be able to implement the diagnosis. Now, the third thing, with those people who do not have the definitive treatment, I think we should have a provision to create a research platform where we collect some biological samples and store them. It may be of great use to that. One of the ways to cut short the economics in all these efforts is one is the telemedicine. I think this has to be used very effectively so that people need not travel to different locations, and we can channelize them. Looking at the centers of excellence should get connected to the periphery so that we can give an opinion and then guide them. That's the first thing. And we should be able to provide sample collection opportunity at different levels and transportation to the center of excellence, so that that is another way of cutting the cost. And training and orienting the family is the most important thing. And in this, I think we should utilize all the voluntary organizations to put their effort. So this is what I feel. The grouping into different categories.
Very insightful, Dr. Venkatraman. The part is, I think you mentioned about the awareness. The two things here, I was just asking Dr. Kabra, that, we have the central funds. There are also the state funds that are mentioned in the policy, right? So, how does the state government actually enable its funding mechanism if the awareness is a little bit on the lower side? So is there something that can be done on that front so that the states also start with, so there'll be a force multiplier effect across the country?
Right. So, Dr. Bhaskar, actually, it is not across the country that the states are not aware. Some of the states are not aware. And as you must be knowing that in the initial policy, many states had that, comments were received from many of the state governments that we were not aware that this kind of policy is being made and what is our role. So the clarity was not there. And even in this 21 policy, the states were not clearly aware that if we say group 2 is to be funded by the states, how to go about it. There was no clarity. So now this funding issue all across states, this can be done. So now I think you must be knowing that in Karnataka, funding is there, crowdfunding is being raised. Even some of the ministers are donating money for the patients. In Rajasthan, the government has come up with their own portal for CSR. So I think it will gradually improve, but I think the states where and we know that from like which states are actively involved in this and which states are not. And I think as a part of the awareness program which has been emphasized, I think all the state governments should be taken on board, and the stakeholders in the ministry and maybe the bigger medical colleges there or bigger institutions there, people can be brought together, because I'm reading the questions and there's quite a lack of clarity about how to go to a center of excellence and how to get funds and all that. So all those people should also be aware that how it can be done. And I think it would be a good activity. And this was actually a plan earlier also to bring all the state government stakeholders to sort of educate them. I mean, it in a way that how, what is the plan like and how the networking has to be done. It's extremely important. The person in the periphery must know that how and where the patient has to reach to get some financial assistance or even a diagnosis. As Dr. Venkatraman said, maybe just posting the sample and having a telecon or something like that. I think that's important. One more point which I wanted to add when we were talking about CSR. And when we talk about CSR, I mean, most of the time, the CSR for rare diseases is totally different as compared to CSR for, say, HIV or for, say, COVID or something like that, right? So most of the CSR donors would have something like a one-time grant given. It may be a very high, I mean, maybe in crores, but then that would be for infrastructure building or rehabilitative services or COVID diagnosis or something like that. Here, we may get CSR for establishing centers or maybe filling the gaps for diagnostics, and people would be ready to give that. But here what we need is the support has to be sustainable if we are talking of treatment. And if we tell somebody that we would need these many crores of treating this number of patients lifelong every year, and this would escalate as the weight of the patient increases, I don't think it will be sustainable through CSR. So there have to be other mechanisms also coming into picture, pooling things together, then only it can be done. So CSR for treatment, for long-term treatment and very expensive treatment has really, I mean, we really need to understand that how are we thinking about it. So these are my comments. Thanks.
Thank you, ma'am. And Dr. Gulati, you're back now, so it's good to see you. The part of, again, sustainability. So with your experience, we talk about different ways of sustaining the entire therapy. Sometimes it's difficult because the amount of money is so limited, and CSR, there's no channelization of CSR or other things. So in this scenario, someone who requires long-term therapies, what would be the sustainable measures here? What do you envision this entire piece to be?
It's addressed to me, Dr. Bhaskar?
Yes, ma'am.
Yeah, sure. No, sorry. Actually, trying to go between two webinars becomes confusing. I have my half. Sorry, I had to introduce the speaker because that's what I'm organizing there. Actually, regarding what we learned from the series of webinars which we had done for the same financial advocacy grant you got from Global Genes, as we got, we something basic. I feel from the whole financial point of view, firstly and foremost, I think we need to empower the clinicians as well as the parents about this and the holistic multidisciplinary treatment, because what happens is parents just go on chasing the newer, they go on to see which are the trials going on and all, and they just go on chasing that. And the multidisciplinary supportive care, which is the backbone of any condition, every condition will have some kind of a multidisciplinary supportive care. More so, like we had the series only on DMD SMA, so that means that has to continue, which we forget. One. And then second thing is regarding the treatment. One, yes, the trials which have to be done globally, and our patients should have access to that. That is happening now quite a bit. The trials, indigenous trials and indigenous products based on the same lines would be maybe the game changer, because the tremendous amount of cost which is there. Just for giving you one example, for a DMD patient who's 30 kgs, the cost of the atalurin, which is the stop codon read through, is around 3.8 crores per year. And then if you are talking about all those exon skippings, it vary from 6 to 8 crore a year. And if you're talking about SMA, it's 16 crore 1 year for the Zolgensma, but that is one time thing. But the Spinraza, which comes to be around 4.1 crore the first year, because you have loading doses, and then 2.1 crore thereafter. And Risdiplam comes off around 2.1 crore per year. But when Risdiplam was launched in India, Roche has given a package deal to the parent support groups and the parents. You buy something, they give something free, so it comes around 1.4 crore. So they cannot reduce the global rate. They have just given some package, so that may help to reduce the cost. One. So but other thing is very important, that indigenous molecules being developed would be very important to encourage research that may bring down the cost very tremendously. That is why in the webinars we had global the representation from all the pharma industries, and also from the from all the funding agencies. And again, the amount of cost the funding which will be required was also discussed, and they are all encouraging to do fundings. And there needs to be a partnership, and like suppose our patients are all getting all these exotic new drugs for DMD SMA on the SMA because of humanitarian access programs, but they cannot be continued lifetime. It's not sustainable for a pharma company. So it was also discussed whether at an international level they can have some donations, and that donations corpus can be given to those pharma companies to have maintain a humanitarian access program. We had Mr. Sandeep, and also from the other most common the platforms, in India, we had and discussed about crowdfunding in the commercial setting, and we had Dr. Swasti Charan's side, they talking about the crowdfunding from the national level, which is not going on as Madam has already pointed out. So that is there. And we it's also important. We had the employees beneficiary scheme people. We also had some financial people who came and discussed. So actually, you have as the government the funding which is there through the rare disease, that will be there. We have to ensure, and we did discuss and pointed out to ma'am that, and we told Dr. Swasti Charan also that, and in the next meeting, I hope ma'am will ensure that not only the treatment, but the supportive care requiring the vaccination, what we need to give, the ventilatory support and all that, you need those BiPAPs and all those will be also funded by the rare disease thing. So, I mean, that would be there. And like we also try to talk to CGHS, ESI and all. We had some other companies come up who talking about their employee schemes. So they were giving, but the only amount is they started to give. Coal India had given for one of our patients, got 16 crore Zolgensma through Coal India. They were approved only also for a second patient, but they wanted the response to be seen in the first patient before they gave to the second. And in that due time, and that second child went on ventilator and passed away. So I mean, this is a very it's a very tricky situation. And two more problems I wanted to flag was that as you get one crowdfunding successful, I think there must be thousands of crowdfunding which are not successful. And I got one patient, we get that flagged. Even one of my patients got crowdfunding through Impact Guru. But that patient had approached so many people, and his case was put on Kaun Banega Crorepati by Amitabh Bachchan and Farah Khan and all. So it just got got so much publicity. But but it doesn't happen for everybody. One of the parents who came to me in the OPT, I came to know that they were sitting outside the Puri temple asking for money. So I just when all this situation is causing so much of dilemma for the parents and so much of stress for the parents that they're so desperate. I think another thing, I need them to be empowered of exactly what treatment available. Out of the 18 court cases which had come for the High Court, the thing for the DMD, when they had come to Dr. Madhulika, then their patients were called, and I had seen all the 18. Two patients who had put in the court case were not even amenable to the exon skipping. So they were running around and they were not aware. So I think you need to have complete awareness, professional as well as parents, and try to streamline and come at a bottom way. So we will have some pharma will have to come a step forward. You may have some donations come up, some crowdfunding come up, some indigenous products coming up, some employee support. But also we have to work on the coping strategies for the parents, not just help them when they're depressed and out. Just tell them and have a holding hand. And I think the parent support groups have a very, very major role to play in this long run. And I mean, it is you, and they should not be blaming anybody. And I was on last Sunday, I was in one meeting. They said, Acha, I'll put a PIL. Menika, please don't put, and they'll put a RTI. I said, that waste time. Don't do something like that. I mean, it's just that we have to work towards, and then, like all these humanitarian access program medications, the government had exempted all the custom duties, because the custom duties on 16 crore is going to be so much, right? The government is doing that. So the pharma is asking to have some blanket exemptions. So I mean, there has to be a meeting, and in ICMR we had two meetings in which in one the parent support was brought with that, and the other one you had the pharma on board, which was headed by Dr. YK Gupta. In that it was being discussed how a middle path can be come, because putting the ball in one person's court is easy, but it is not sustainable, as that word you said. I think we all have to think and do, and don't forget the parents in the long run. And the parents also should remember, when they're applying for humanitarian access program, should not apply from two institutes. You are making another child lose the opportunity. Because we had for nusinersen, we had 38 patients who got approved in the second lot, out of which two had got from PGI and one got from Gangaram also simultaneously, because they gave a different address book. They were desperate, I understand, but in the bargain, 3 patients have been denied treatment. So just think about 3 more potential. So we have to not think about self. We have to think of all the suffering humanity together in that situation.
Very insightful, ma'am. Thank you for that. I think we're 15 minutes above time, but I think we should just say something about the people who have raised a few questions. I'll just read them out, maybe for our next discussion. Vasant Rao sir has said that only government bodies qualify for CSR funding. That too, funds have to be utilized for infrastructure developments and not for treating patients. So that's another side of the story, a very insightful one. The policy, therefore, has to change in this regard. So that's a query that is there. We also see that there are lots of questions around around the understanding of people. So I think awareness, if people are aware, a lot of things can actually move in the right direction. So that is something, again, probably Indo-US RARE should think about in terms of how do you create more awareness across the country. We talked of the portal. So someone was asking about Gunjan has been asking about how does the government promote its portal. So there's a need that I can see that people want in terms of awareness. They've also talked about the clinical trials. How do we get more more people into the CT in India? We had a lot of clinical trials happening outside the country, but now can we actually promote those clinical trials in the country? So a lot of insightful steps and things are there. Again, in terms of understanding of the 50 lakh per patient, I think that clarity needs to be there. It may be written in a policy, but the fact is people still need to understand more because they still have questions like, is it 50 lakh per patient one time? Is it, how is it going to be used? So I think a lot of clarity would be required, and probably during the next time, I think Indo-US FRARE should actually do something where on a large scale, where such issues are actually handled and suggestions are provided to the right forum, so that step by step, small steps maybe, but we at least start addressing one by one. So that is something that is there. So I think I'd like to thank each and every one of you for having been a part of this panel. But I think there is also a launch of the document, Nisha. I think it'll be great to actually use this forum to launch the paper or the report, for that matter.
Yes, sir. If you could take over to take over the launch, and if all the panelists please hold up the cover.
Absolutely. So everyone has the part. So I think Dr. Venkatraman, if you could just hold it a little bit higher so that there could be a photograph that could be taken. Dr. Kabra, Dr. Gulati, if you're there, Tripathi ji. So I think that is something which is so kind of you to actually having to put it up. Nisha, is that visible? Is there something that is?
No, I think it's not visible from. No, it is actually. If you hold it.
Yeah, it is. There is some. Brightness. I'm not sure.
Yeah.
And the picture may not be clear, but
the
we are
virtual background.
Showing it.
Yeah, but you can remove virtual background.
Give me 1 second. Yeah, I'll try to remove that. I think I have, but 1 second.
Yes, you are right. Where there is no virtual background, it is seen clearly.
It's clear. You're correct. Yes.
Yes.
Just give me a second.
Meanwhile, can I make a comment?
Please,
one of the problems which Dr. Gulati has made people duplicating, applying to different ages is purely out of desperation. Of course, some kind of errors do happen. I think it is time that we create a registry, national registry, where each one will register and will have a unique barcode. Once you have that barcode, I think everywhere it will be useful. More important than misusing the system, very important for us is to develop a tracking mechanism. What happened to any remote corner of the country, one patient or one person registers, we will have a good tracking mechanism, whether it has been diagnosed, whether it's been given treatment, what is happening, what is the outcome. So at the end of it, we are looking at only funding, but we also need to know the data, what's happening to each one of these people, so that we'll have the sufficient mechanisms to rework on the entire system and to take a recourse. So it will solve the misuse problem, but at the same time helps us to track the whole system. Thank you.
Absolutely.
I'm sorry. I think it will not be possible for me to switch the background after we are all on the call. So it doesn't allow me.
I think it is being seen by.
I think
it is visible. So that's
it
fine.
is visible.
Yes.
I think Dr. Gulati's one is visible the most. So that's and she's there. So thank you so much, everyone. It's been a pleasure to speak with all of you, and we hope we can actually take this forward again in a way that we can actually support patients of India, not just 1, 2, 10, 100, but maybe thousands and more than that in multiples. So thank you again for all the support, all the help, and all your time. It's been an honor for me to actually be here. Thank you so much.
Thank you very much. Thank you.
Thank you very much.
Over to you, Nisha. Over to you.
Thank you.
Ramya, sorry.
Yeah, Ramya will be taking over for a brief vote of thanks. Thank you all panelists from my side and from Indo-US Rare. Ramya, please take over for the vote of thanks.
Yeah, thank you, everyone. Thank you for participating here. Hope you have been enjoying the incredible, insightful panel discussion. So please take a couple of minutes, to fill in the survey that have been pasted in the chat link. So all the questions that were not answered live have been noted, and we'll work to get to the answers to you offline. Please also note that the recording will be available on the YouTube channel, and our report on the topic of the financial advocacy in rare diseases will be released, and it will be available for download on our Indo-US Rare website, which will be widely disseminated across all our social channels. So thank you again for participating in today's webinar event.